Chapter 31, Lower Respiratory Disorders of the, this is on page 572. Here are our learning outcomes for you, just to kind of have for outline. Okay, we're looking at bronchiectasis in the airway here. This is a dilation of the bronchial airways. They become flabby and scarred, so bronchiectasis can remain localized or spread throughout the lungs. I'm reading from page 573. Here are our signs and symptoms. These are all kind of very similar. So you just have to know this are abnormals, and it's going to be something involving the lower respiratory tract. This is what you hear in the lungs: crackles and wheezes, coughing. We can use these different diagnostic tests for the doctor to diagnose. The types of interventions are going to be antibiotics, mucolytics, expectorants, bronchodilators, physiotherapy, that cupping, oxygen, and they can advance to a surgical resection. Pneumonia. Something that you will forever be, it's in the forefront of your nurse brain, because pneumonia is something that they can get as a secondary infection from multiple different things in the hospital. They can be there for other comorbidities. These are acute lung infection, and this can kill them. Their alveoli are filled with exudate. These are secretions, basically, right? So they get those heavy secretions or coughing up all this heavy mucus and junk. It can be discolored. Bacteria, usually it's strep. Virus, it's a fungal. You can have an aspiration, a pneumonia, and die from that. Who is at risk? The very young, the very old, those that are immunocompromised. Forever in your nurse brain, I hope. This is for most things, but absolutely pneumonia and the very, those that are intubated are definitely at risk for pneumonia. My friend Jay, I tell you about all the time, he is at risk for pneumonia always, forever, because he is immobile. So anyone that is on a trach, that's immobile, you are a prime candidate. That's why you have to be relentless about suctioning, proper, for someone that is immobile, you want to make sure that you're turning them, moving them, and doing all the things that you best can for having their secretions to a minimum and that bacteria not being built up. So even the 2x2s and 4x4s, keeping the stoma area clean. You don't want to have any introduction for more bacteria. Prevention, you can get the vaccine. So we have a pneumonia vaccine. Coughing and deep breathing, always very good. That's why we have them use an incentive spirometer after surgery. Hand washing, always frequent mouth care. That's what goes along with stoma care for someone who is on a trach. We look for chest pains, fever, chills, coughing, dyspnea, yellow, rusty, or blood-tinged sputum. We'll hear crackles, wheezing, malaise, absolutely. So this is pneumonia. If it's a new onset, especially in the elderly, we will see confusion, lethargy, fever, dyspnea. They can get pleurisy, a pleural effusion, atelectasis, for spread of infection to the rest of the body. They become septic, they can die. Here is an illustration, and this is on page 579, following along with your textbook. There's some boxes that you should make sure that you look at, like the gerontological issues on 578, evidence-based questions on 579, These are the summary is on table 31.1 on page 579. Those little highlighted areas, read all of those. Pneumonia is something that you need to be experts at and looking at and being aware of them and looking for signs and symptoms of it. Doing prophylactic action, nursing actions to preventative measures for your patients not getting a pneumonia. Okay, antibiotics by mouth or IV, antivirals, bronchodilators, expectorants, oxygen fluids, getting your patients up and moving, physical therapy. You guys are really good about walking your patients. You know how important that is, getting them just to sit up on the edge of the bed, having their feet over, they're dangling, just moving around the room, maybe starting off there, but we need to get them moving. TB, page 579, it starts. Okay, you get a TB every year because you are exposed, being a healthcare professional. This is a acid-fast bacillus. Immune system keeps in check, 5 to 10% infected become ill. Okay, so it is highly contagious. That's why that we do so much to make sure that you don't get it. May activate with impaired immunity, always immunocompromised, new immigrants, people that have not been immunized against it. That's why new immigrants are included, those with HIV, they're immunocompromised. If you're living in crowded conditions, elderly alcoholics. Why alcoholics? Why they're immunocompromised, right? Okay. Coughing, blood-tinged sputum, night sweats, anorexia. You see similar diagnosis here. These are all lower respiratory disorders. So that heavy cough, that's not normal to have that heavy productive cough like that, with sweats, fevers, ongoing, that's not normal, right? So these are the different tests that we will do, the doctor will order so that he can diagnose. Medications. So we're looking at page 581. Here are options for nursing diagnosis. Impaired gas exchange. So we want to monitor their lung sounds. They have dyspnea, mental status, alteration, peripheral. So their cap refill, our O2 is going to be affected. ABGs will be abnormal. Again, you can reference back to that chart that I gave you. Oxygen, deep breathing exercise. Again, you want to discourage them from any smoking if they are still smoking. Ineffective airway clearance. So you want to monitor how much sputum they have, what is the coloration, what is the viscous of it. So is it very very viscous, or is it thin? Is it really thick? And you can see where it's barely coming out when you suction, or when they cough it up, or it's just thin, it's thinning out, then it's resolving. Encouraged fluids are going to help this a lot. Deep breathing, get it up and get it out. Coughing, that's why we give them expectorants. Turning them an ambulation is very, very important. The cupping or CPT is really helpful as well. Like those vests that they put on, it's a cough assist. You want to get all that stuff out, all those secretions. Okay, monitor the respiratory rate, SpO2s, their ABGs. Why do they have an effective breathing pattern? Positioning and teaching them proper breathing exercises will help them. So diaphragmatic breathing, and so it's deeper breathing all the way to their diaphragm, filling up their lungs, right? So we want them to have that, not shallow breathing. Activity intolerance. So this is what you will have for that. Teach patient and family, take drugs as scheduled, consider home health, avoid spreading disease to others. So Basically, you want to stop the spread of any kind of TB that they might have. Infection, this is full PPE. Pleurisy or pleuritis. This is inflammation of the visceral and parietal pleura. Okay, and this is something that we see secondary to pneumonia, TB, and or cancer. Sharp pain on inspiration, shallow breathing, fever, elevated white blood cells, and friction rub. A little bit different here. Chest x-rays, CBCs, we see all those different things here. Pain management, treating underlying cause. That's what you want to do. What's the patho? Excess fluid between the visceral and the parietal pleura. The fluid not reabsorbed and your lung can collapse with a pleural effusion. Okay, here's your etiology. We see dyspnea, pain, cough, tachypnea, and diminished lung sounds with pleural effusions. Those are our tests. Treating the underlying cause, pain, analgesics. You might have a thoracentesis or a chest tube in place. Our patho. This is pulmonary fibrosis now. We are on to, page 583. We'll hear crackles, chronic coughing, fatigue, clubbing. This is clubbing of the fingers. Our diagnostic tests, about the same. Here are our interventions, so medications, oxygen, vaccine. You can have to have a lung transplant possibly. Okay, atelectasis, this is on page 584. This is a collapse of the alveoli, most common in post-surgical patients who do not cough and deep breathe, so they're not using the incentive spirometer or anything like that. They're not able. This is a high importance to use it and try to get them so you can avoid this happening. Cough and deep breathe. Okay, these are the things here. A nursing diagnosis. Okay, obstructive disorders, airway obstruction, difficulty with exhalation. Okay, this diagram is on page 586. COPD, you absolutely, like pneumonia, need to know about COPD. So many people have COPD in our area where we live. Table 31.3 should be your friend, and that little diagram above 31.4. Get to know these. This is what's going on with COPD. Their bronchioles are closed off. So you can see here, this is a great illustration. This is lungs with emphysema. Here's lungs with chronic bronchitis. This is a normal lung. You see the difference? It's open freeway here. This here is like backed up, clogged. It's a roto-rooter because it's completely, like, only that little white area is where they're getting air. This is what you want, right? This is clear breathing. So this is what makes people short of breath. It's chronic inflammation, low-grade infection. They're immunocompromised. They get pneumonia, different things. Emphysema, destruction of the alveolar walls. Air trapping, impaired gas exchange, yes. Air trapping here, and chronic airflow limitation. So here's a normal inspiration. You see here, it can go all the way through the alveolar. And then this is reduced, so it's being closed off, so it makes sense, right? Okay, smoking, passive smoking. So this is like you can have quit smoking 15 years ago and you're still going to have emphysema. This is from pollutants that we have in our air. What are our effects of smoking? The damage done. So, of course, you want them to smoke. Yes, it does make a difference. However, when you have severe heavy-duty smoking over years, you have severe damage that can be done. And if you don't quit, it definitely will impact your respiratory functioning. It is self-explanatory, people. Don't ever pick it up. If you are a smoker, please quit. Do everything you can. As a healthcare provider, you want to be healthy. Signs and symptoms. Continuing, this is what we are looking at. Barrel chested. You can see how much distress, how horrible it is to be struggling just to take a breath. Wheezing and crackles we will hear. Chronic cough, dyspnea. We're going to see mucus plugs, emphysema, diminished breath sound, dyspnea, progressive activity intolerance. They are out of breath just walking around the room. They sound like they have run a marathon. Okay, these are some complications. Diagnostic tests that will be done. And interventions, top priority, stop smoking, oxygen, supportive. Okay, all these things here are end of life planning. Bronchodilators, corticosteroids, expectorants, right? You can do nebulizer treatments, inhalers, lots of medications, and it's going to be something that they're dealing with. These are our options for COPD nursing diagnosis. Asthma. Okay. Something very familiar to a lot of us because it's very common in our area as well. 300 million people worldwide. It's hereditary. You can inherit this. Airborne allergies are triggers. Pollution, smoking. So you don't have to be a smoker. Somebody around you can be smoking, and that's a trigger. Infections, allergens, sinusitis, exercise can cause. You can have exercise-induced asthma. Stress can cause you asthma, an asthma attack, or some medications. These are our signs and symptoms: shortness of breath, wheezing, coughing, sputum. Use of accessory muscles. You can see them, the accessory muscles working hard, and it can be worse at night. Here are some complications. Respiratory alkalosis progressed to respiratory acidosis. And yes, it can be life-threatening. They can be intubated and die from an asthma attack, a severe asthma attack. You want to get a very good H&P. These are the tests. Do they have allergy testing that can be triggers? Monitoring with peak flow meter. Avoid triggers. Peak flow chart. This is to help them to increase their lung capacity. So that helps. You can read about that on page 592. This is just a little chart that helps them to, so figure 31.9. You saw that green zone, yellow zone, and red zone. So green is go, that means it's doing well. Yellow, it's getting worse. And red is obvious, we're in trouble. And these are high priority if you're triaging anything that is threatening airway, right? Bronchodilators, corticosteroids, all of these. Oxygen, of course. Patho. And this is CF, cystic fibrosis. Okay. 5 feet apart, I showed you about that movie. So this is page 594. That gives you a good overall kind of I'm going to try to put some channel links on my YouTube so you can look at other CF. Signs and symptoms: thick, tenacious sputum, finger clubbing, foul-smelling stools. These are all things that you're going to see with CF. They do a sweat test, chest x-ray, GI testing. We want to hydration, obviously, inhalant, hypertonic salines, bronchodilators, corticosteroids, frequent hospitalizations, medication here. These are lung transplant possibly. They're severely immunocompromised. Pneumonia is always a risk. PE. This is a pulmonary embolism. You hear about this. 597, you can develop a PE and die. So this is a deep vein. It's similar to like a blood clot, right? So it's a foreign object that travels through the bloodstream, a blood clot, air, or fat. It can be a PE. So if you read on page 597, those are everything you need to know. DVT, most common, fat emboli from a compound fracture. These are complications from fracture, right? Amniotic fluid, so it can be a complication from having a baby. Prevention, regular ambulation, prompt treatment of a DVT. Anticoagulant medications for high-risk patients. So Lovenox injections, maybe other anticoagulants. Signs and symptoms: sudden onset of dyspnea. This is sudden tachycardia, tachypnea. You kind of know that something is wrong. But you have to act fast. D-dimers. These are the tests that we're going to have done. Lung scans, angiograms. They're going to try to find out where it is. These are what we can do for therapeutic interventions. Our options for nursing diagnosis. Pneumothorax. Okay, so this is you can have a lung collapse, a partial or a full. So those are the different kinds: spontaneous, traumatic, or tension. And here are the illustrations here, right? You can be impaled by something like a knife. Shallow rapid respirations, asymmetrical chest expansion. So this is when we're looking at doing an assessment. If you see asymmetrical chest expansion, you know that maybe they have a partial or a full lung collapse. If you see some abnormalities there, asymmetry. Tension pneumothorax, tracheal deviation, bradycardia, cyanosis, shock, and death if it goes untreated. Our diagnostic tests, therapeutic measures, we want to monitor respiratory status. These people need to be closely monitored. Any changes you need to report. Rib fracture. Okay, so this is trauma, cough, CPR. Can happen to cause control pain. Encourage, you can't cast them. You can put a brace on them sometimes, a doctor will. Multiple rib fracture. This is flail chest, or a rib cage not able to maintain bellows action. Care, monitors, ABG. Let's see. This is on page 601. Our nursing diagnosis options. Acute respiratory failure. Page 602. Okay, worsening ABGs, decreasing, restless confusion, coma, and death. Yeah, this is serious. This is what your ABGs are going to show. This is ARDS, or respiratory distress syndrome. We'll see this comes from acute lung injuries, sepsis, shock, or aspiration. Not usually in patients with chronic respiratory disease. So this can be someone that's completely healthy. You can hear fine crackles, respiratory acidosis, restlessness, confusion. 40% death rate's pretty high. Nursing diagnosis options. Absolutely anxiety, right? This is, you can't breathe. Lung cancer, small cell, large cell, adenocarcinoma, and squamous cell carcinoma. This is on page 603. Another big, huge cancer. Men a little bit outweigh women here. There's a lot, obviously tobacco smoke, 80 to 90% of lung cancers, but you do not have to have get lung cancer from smoking. Environmentals, asbestos, arsenic, pollution, just basic pollution, secondhand smoke. These are our signs and symptoms, usually none until late. Productive, cough, recurrent infections, pleural effusion, superior vena cava syndrome. These are all the things you need to look for. These are the tests, some of the tests that we can do. Here is a lung picture on page 603, figure 31.13, along with cancer. If there's a tumor, chemo, radiation, so they might have to surgically remove. So here's a good illustration. Of what and how they will remove it, depending upon where it is at. Sometimes they are non-operable. Chemotherapy is extremely effective. They are seeing small cell cancer is extensive. This is what my mother-in-law had and has, and she had 3 rounds of aggressive chemotherapy, and it nearly eradicated all of her cancer. So she had a 7-centimeter tumor and then had metastasized. So you can see this diagram of what happens. So non-operable, she was told. And so chemotherapy advances have been so great that, praise God, she is almost, her cancer is resolved. We're going to look at, these are our nursing diagnosis options: pain, constipation, grieving. All these things are very ineffective balance because of the chemotherapy. Thoracic surgery, page 606. These are what they do to correct the lung cancer if they can operate. ICU, monitor vital signs. They might be on a ventilator, chest tubes after surgery. They also can do it with the Da Vinci robotic now and make a little tiny incision. It's amazing. You have to remove a middle lobe of the lung. Nursing diagnosis. Okay, here are your review questions. There you go.